management from the point of view of the diabetologist. With us, Dr. Nizar Shouqi, consultant diabetologist. Yes, Dr. Nizar. تفضل.
First slide, please. Learning objectives.
Yes. First slide, please. Yes.
The learning objective of this lecture is as follows. First thing, treatment in hospitalized diabetic patient, which is very important. What are the bases of the treatment in diabetic patient inside the hospital? Second thing is the choice of a treatment, depending on the comorbidity. The effect of comorbidity and the choice of treatment is very important and linked together. Third thing is the hemoglobin A1C goals. Dr. Safa have mentioned some of it, but the exact thing is the individualization of a treatment according to the comorbidities to reach which level of hemoglobin A1C suitable for every patient. The last learning objective is the SGLT2 inhibitors and GLP-1 receptor agonist general consideration. So that because now the cardiologists, all of them are looking for the SGLT2, but there are some general consideration which is very important to know about the GLPs and the SGLT2. Next slide, please. Now, every patient who is inside hospital should have an A1C test if he is diabetic, because we have to know that diabetes is recent or old. And everyone with hyperglycemia, blood glucose more than 140 should have a hemoglobin A1C. This is by the American Diabetic Association. Our patient have a hemoglobin A1C of 11. Now, a hemoglobin A1C of 11 is indication of an improper treatment of the diabetes previous to the admission to the hospital. Now, insulin, if should be administered, and it should be administered in this patient, it should be using validated written or computerized protocol that allow for a predefined adjustment in the insulin dosage. That to say, you don't sit by the side of the patient and decide what to do and what to give and how to give and when to give, especially by writing on paper or giving it to the nurse. There should be protocols, and those protocols should be by the hospital or by the guideline in order to follow these protocols in a proper way. Now, the third thing, when caring for a hospitalized patient, a diabetic team should be available in the hospital, or at least consult a diabetologist, because this is very important. Next slide, please. Next, please. Now, glycemic target in hospitalized patient. I have this patient now, what I should do? Where should I go? The threshold should be between 140 and 80 milligram per deciliter. This is a critically ill and non-critically ill patient. Now, a more stringent goal, such as 110 and 140 milligram, is only advisable in some of the patients, like those who go for an open heart surgeries and some of the surgical operation, thoracic operation. There is a very nice study by the NICE sugar study that said it is a proper thing to go between 140 to 180, because if we go to 110 to 140 as a goal inside the patient and inside the hospitalized patient, then morbidity will be increased. Next slide, please. Now, the monitoring of a blood glucose bedside. It depends on the patient if he is eating or not. Who are eating, then you should do it before meals. If he is not eating, then it is at least 4 to 6 hours. Of course, the continuous glucose monitoring has not been approved by the FDA for inpatient use. The glucose testing ranging بالinsulin infusion from every 30 minutes to every 2 hours. Next slide, please. The treatment that can be used is as follows. Either basal insulin or basal plus bolus correction insulin. Basal insulin is the long-acting insulin. Basal plus bolus correction insulin, bolus insulin is the short-acting insulin. So it's long-acting insulin, short-acting insulin with a correction insulin. Now, this can be used in patients who are on poor oral intake or nothing by mouth. Now, if the patient is eating properly and he is not so much critical, then basal brandial and correction. Basal brandial, long-acting basal, short-acting brandial, and a correction dose, also insulin. Now, one of the most important things is that we don't use pre-mixed insulin regimens, and is not routinely recommended inside the hospital because of the risk of the hypoglycemia. Next slide, please. Glucose-lowering treatment in hospitalized patient. A sliding scale, which we usually use, is strongly discouraged. In Iraq, we use the sliding scale very commonly inside hospital. So it is strongly discouraged. What you would use is using insulin, and what we should use is the recommended protocols that is either computerized or validated by certain protocols or certain. We have an example later, we will show it to you. Now, analog and human insulin, what is preferable? It's the same. And the result, as for glycemic control, insulin or human insulin is the usual insulin that we use. Those guys with the green and the yellow and the brown things. يعني الانسولين العادي اللي احنا نستخدمه. والانالوج هي البن اللي هي جديده كلها. فusing this or using this is the same in the similarity. Next slide, please. Next slide, please. Glucose-lowering treatment in hospitalized patient continuous. Use sliding scale as we had said this one. Next slide, please, Hila. Now, for anyone who is interested in what to do, what kind of insulin, the dose of insulin, and look at the arrows on the left side. Each step, hemoglobin A1C, total daily dose, when to use it, how to escalate it, how to increase it. So if you are interested in giving insulin, you can go to this protocol and look for every part of it and know where your patient is, and we can add or decrease insulin. So these are the protocols we are talking about. You should follow these things, not sliding scale. Next slide, please. That? Hello?
Yes.
Now, regarding SGLT2, they are not recommended for routine inpatient hospital use. So if you have a patient who is critically ill and inside the patient, don't use SGLT2. Now, I know that the cardiologists all are looking for SGLT2, but please look for the special things in SGLT2. FDA has recently warranted that SGLT2 inhibitor should be stopped 3 days before scheduled surgeries. Sodium glucose SGLT2 should be avoided in which cases? Severe illness, ketonemia, ketonuria, prolonged fasting, and surgical procedures. Now, the FDA also have said that sexagliptin should not be used in heart failure. This is the new, and allogliptin in people who developed heart failure. Avoid it, please. These are for few things in inpatient hospitalized patients. Next slide, please. Dr. Hilal. Regarding the simple treatment inside hospital, the question is, our lady should be treated in the hospital by which kind of treatment? Is it insulin infusion? Is it basal bolus insulin regimen only? Do we add GLP or do we add SGL2 or none of the above? You can participate in this. And it is obvious and simple question. Dr. Hilal?
Yes, Nazar.
So everybody can answer this question, yes?
It's a simple question.
Yeah.
Please put your answer in the chat box. Can you repeat the question, Nazar?
Regarding this lady inside the hospital, now we receive this lady inside the hospital. What kind of a treatment, what should I do for it? Should I start insulin infusion? Should I have her on basal bolus insulin regimen? Should I add GLP-1 RAS? Should I add SGLT2 inhibitor or none of them? What should I do?
Till now, the main answer is that on option A. Most of the answers are few option C. But most of the answer A.
Most of the answer is insulin infusion only.
Yes.
Yes.
Which is not the proper answer. Insulin infusion is restricted, as we said, by the NICE sugar study, is restricted for a specific patient. And those who are in intensive care unit, not all of them should be used on insulin infusion only. The proper answer is to go for the basal bolus insulin regimes and correction. This is the best answer. So please remember this. Go for the next slide, please. Key consideration in use of SGLT2 and GLP-1 receptor agonists for cardiovascular risk reduction in patients with type 2. Now, the first one is from the American endocrinology, ACE, American cardiovascular disease. Look at this part of the treatment. Initial, a patient, clinician should discuss the proper treatment of SGLT2 and GLP-1 with patients who have one of these things, اللي هي atherosclerotic cardiovascular disease, heart failure, and diabetic kidney disease. Any patient who have those should discuss the treatment of SGLT2 and GLP-1. In addition to other treatment, which is the lifestyle and the metformin or whatever we'd like. This is part. Next slide. Please, next slide.
Just wait, Nazar, please.
Hey.
I think the share have been stopped to you.
Why?
Why? Do you hear me?
You have the share or not?
I'm having
Yes,
the
Doctor.
slide, the last slide.
We have the share, but I think it is a frozen slide.
Yeah, it's
Not
frozen.
Just one moment. I will stop it and return it back.
It is frozen. Okay.
Is it now okay now?
Same slide.
Okay.
Screen is on, and yeah, mouse is moving.
Okay.
Yeah, yeah.
Yes.
It's very good now.
Yes.
Now, this is the American Diabetic Association. It is the same thing. This is the American Diabetic Association 2022. Look at the second statement. Glucagon, peptide 1 receptor agonists, and sodium glucose transporter inhibitors with or without metformin should be used in all these patients that we mentioned above, which our patient is one of them. So she should have these treatment prior to this acute stage, not in this acute stage, but a prior to this acute stage. Now, still, the American Diabetic Association consider the comorbidity and patient-centered treatment factor is very important in choosing the disease. Comorbidities, our patient have every comorbidities that's present. She have macrovascular and she have microvascular. Patient-centered treatment, social, economic state, can she buy it? Is it availability of tertiary centers? This is very important thing in choosing the treatment of this patient. Now look at the third statement. Metformin should be continued upon initiation of insulin therapy, unless, and the big unless here, which is unless contraindicated or not tolerated. cardiologists usually disregard metformin, while diabetologists always love the metformin. But it should be not contraindicated, and it should be tolerated. It should be kept when patient is on insulin. Next slide, please. Now, this is also from the American Diabetic Association. Look at on the left side where the blue arrow is. Established atherosclerotic disease or chronic kidney disease. What should we do? The American Diabetic Association said that in case of atherosclerotic cardiovascular disease on the left side, extreme left side, then you should use GLP-1 first, okay? Which have a benefit in cardiovascular disease, or not add, or SGLT2 inhibitors with a proven cardiovascular benefits. If, look at this one, if eGFR is adequate. Now, you don't use SGLT2 like this. There should be an adequate estimated glomerular filtration rate. Now, the second column is also important. Those who have heart failure and those with a chronic kidney disease, you begin with the SGLT2 or then GLP-1, okay, which have a benefit on chronic kidney disease and heart failure, and it's GLP-2 not tolerated or contraindicated, add GLP-1 with a proven cardiovascular disease. On the right side, if you look, these are the GLPs who are with the proper cardiovascular, one after another. The best is the first one, more than the second, more than third, more than fourth. And what is the GLP-2, which is available in heart failure or chronic kidney disease, which is best and which is less better on the right side. Next slide, please. This is an explanation of the previous slide. Key concept, if A1C above target, despite recommended first line treatment, and the patient has either atherosclerotic cardiovascular or chronic kidney disease, atherosclerotic, add GLP-1. Add SGLT2 inhibitor with a proven cardiovascular benefit, if adequate, again, GFR. If heart failure or chronic kidney disease is predominant, then start with the SGLT2. If can't take it, then with GLP-1. Next slide. This is a simple slide, a simplicity. Now look at this slide. It's very important slide, and don't be dazzled by all these things. Look at the blue. Now, monotherapy include GLP-1 and SGLT2. Dual therapy include GLP-1 and SGLT2. Triple therapy include GLP-1 and SGLT2. So GLP-1 and SGLT2 are present in mono, dual, and triple therapy, and every patient can be used with chronic kidney disease or heart failure. Next slide, please. Now, this is also a simple fact to treat our patient. Next slide. Next slide. Now, outside the patient, outside the hospital, normal values outside the hospital. This is what our patient should have at the beginning, but not in this particular case in general. Hemoglobin A1C should be less than 7. And the preprandial fasting glucose, it's between 180 to 130. Peak postprandial glucose should be less than 180. This is the important thing here. 1 minute, please. Next slide, Hilal, please. This is one of the most important slides that we can see here. We said comorbidities. Look at this slide. On the left side, imagine a patient who is 35 years old and he have only diabetes for 2 years and no comorbidities. All these things can be applied to him on the left side. On the right side is our patient. Everything she have microvascular, she have macrovascular, she have kidney disease, she have ischemic heart disease, a prolonged diabetes. So the management or the goal of the A1C is between more stringent less than 7, maybe 6.5, in the patient who is 35 years old and he is educated and he have diabetes for 2 years, he have no comorbidity. And in our patient, which is on the right side, which consider that there is, our patient, remember that she had 11 hemoglobin A1C. I'll be much obliged if I convert her into 9, not only 7. If she become 9, I'll be happy. Now, next slide. After stabilizing the patient and discharging her from hospital, the new goal of hemoglobin A1C, less than 6.5, less than 7, between 7 and 8, less than 9. What do you think? Where should we make this patient reach a hemoglobin A1C? Which figure of these is suitable for our patient?
Please put your
Answers.
please put the answers on the chat box. Okay, there are variable choices between 2, 3, and 4.
Yes.
Dr. Hilal, anyone?
2 is more,
More.
and 3 after it. Option 2 and then option 3.
Which one they choose the best, which largest number?
Number 2.
Number 2, less than 7.
Yes.
In our patient. This is wrong.
No.
Yes.
Less than 7. And this patient is critical because we might give her a hypoglycemia. And if she goes into hypoglycemia with a heart failure and ischemic heart disease, she might die. You don't need to give her less than 2. It should be between 7 and 8.
Yes.
This is the most important thing, and this is the most important individualization of hemoglobin A1C. Whenever there is more comorbidities, you go to a higher hemoglobin A1C goal. If you make it less than 7, there is a risk of hypoglycemia, there is a risk of death. So be careful, please. Next slide.
Yes.
Now, currently available SGLT2 inhibitors, this is just the doses of the SGLT2 inhibitors and the type of the SGLT2 inhibitors, canagliflozin, DAPA, IMPA, and ertugliflozin, for patients who, doctors who would like to know the doses and which kind of SGLT2 inhibitors available now. Next slide, please. This is the important one. Please, everybody was speaking about the proper estimated GFR for treatment of SGLT2 or starting SGLT2. Look at this one. This is by the American College of Cardiology. Now, 100 milligram orally estimated GFR 13 to 59. This is in Canada. Now, not recommended for a glycemic control below 30. Dapagliflozin between 45 is not recommended. GFR less than 30 is contraindicated. This is very important. Empagliflozin 10 milligram estimated GFR below 45 use is no. This is important. The American Diabetic Association 222 have said that anybody below 30 estimated GFR should not start on SGLT2. And you can go and see that in the American Diabetic Association treatment in hospitalized patients. Next slide, please. Contraindicating of SGLT2 inhibitors, history of serious hypersensitivity, pregnancy, breastfeeding, on dialysis, end-stage renal disease, DAPA and IMPA, and severe renal impairment, اللي هي GFR less than 30 ml per minute, especially DAPA. Next slide. Now, these are the GLP-1. Exenatide, twice daily, liraglutide once daily, lisexenatide once daily, exenatide once weekly, and diliglutide and semaglutide. And now I think there is an oral part of the GLP-1 is in the market now, I think within the past one month. Next slide, please. Look at this one, type of GLP-1 and indication. To reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. And you can see, apart from the exenatide, which is short-acting, all the others are long-acting. Next slide, please. This is also important. No dose adjustment necessary with renal or hepatic impairment. The data in end-stage renal disease are limited. So in spite of having no limitation in hepatic or renal impairment, but the data is limited. There is not enough data. And there is one more important thing of GLP-1. Remember that the side effect of GLP-1 is nausea, loss of appetite, and diarrhea. It might cause severe dehydration. So in case of low estimated GFR, it might cause a probable worse renal function if the side effect appear. So it should be followed up properly. And in general, it can be used, but with caution. And remember, all of them are saying that the data are limited. Next slide. I think this is the end slide. Thank you. Thank you for listening to my presentation.
Thank you very much for the good, nice information, Dr. Nizar. So now, any questions for Dr. Nizar?
اسمحي لي
نعم.
دكتور عمر
Yes,
مصطفى
تفضل.
kindly is following with us minute by minute the presentation, and he is putting very important documents about diabetes control.
Yes, he noticed that, yes.
Dr. Omar, can you open your mic and your video, please, and to comment on the case and what are the practices that you are doing in UK?
Thank you. Well, inpatient diabetes is a subject close to my heart because that's what I do as part of my job. It's important to add to the points kindly raised that in inpatient diabetes, the main aim really is it's very hard to achieve a lot of targets, but because of the instability of such cases with sepsis, with acute coronary syndrome, with acute heart failure, it's important to make sure that the monitoring scheme is very stringent, very strict, and really, in a lot of occasions, insulin is the only choice. But there's emerging evidence, and the problem with inpatient diabetes is that you can't really do clinical trials except in a very small center, or you happen to be in Texas, where Dr. Imperial is based, and he generated quite a lot of evidence from RCTs. And so in summary, the targets really for glycemia, roughly speaking, between 4 and 11 millimoles, or 80 to 100.
Sorry, Omar, your voice, there is echo. There is echo and weak voice. We couldn't hear exactly.
Okay, is that better?
Yeah, much better.
Okay, so in inpatient diabetes, it's important to avoid hypoglycemia at all costs, and the cutoff of roughly about 80 milligrams per deciliter or 4 millimoles is important. There are some arguments to raise that, and some guidelines may point to that. I put in the chat a series of links to take you to a lot of the new guidelines. Second is avoidance of harm in inpatients is a big thing. So that's hypoglycemia, inpatient DKA, and inpatient HHS, or what used to be called HONC, and foot ulcerations. Big themes. and safe step down of care and closer monitoring are key. Now, the monitoring can be with a capillary glucose, but there's increasing evidence that using things like continuous glucose monitoring, flash glucose monitoring can be useful, but of course you have cost in this case. So I put in the chat a lot of links for people they can follow, and they are, a lot of them are free to download. Thank you.
Okay, Dr. Omar.
Yes, thank you very much, Dr. Omar. Any questions? I'm looking at the chat box. There's a question. I don't understand why the patient was not given any oral anti-diabetic, but injection therapy alone. Dr. Safa or Dr. Nazar, can you answer, please?
Probably Dr. Safa. Dr. Safa can, he is following the case.
Safa, maybe. Yes.
Dr. Safa.
Safa.
معنا?
Can I answer this?
Yes, please.
Yes, please.
The patient is critically ill. She is heart failure, and she is acute kidney disease. And she's coming to the emergency room, and with hemoglobin of 11 and random blood sugar of 300. What kind of oral treatment can be given at this stage? Nothing.
Yeah.
She should start on insulin now, and she was already on insulin, and properly speaking, she wasn't taking the proper dose before she presented to the hospital, or else her hemoglobin wouldn't be at 11. It may be at 9, at 8.5, so she should have taken more insulin before to the presentation. So there is no rule for oral hypoglycemic agent in this case at this point. Okay.
Yes, thank you, Dr. Nazar. Any other question, please?
There are hands up.
I'm not seeing any hand. Yeah. There is another.
Dr. Aram Babakar started.
Yeah.
Exam first. Fadal, Doctor.
Oh, thanks so much, Doctor. Yeah, I think that was a very great and interesting presentation. But I think my question was when the organizer read the question, I think she forgot the most important part of this question, which was.
I'm sorry.
Yeah, I think that's why the answer was a little bit confusing.
Yes.
Yeah. So I'm saying this is the question. Prior to reaching this advanced stage of hair disease, I don't understand really why the patient was not given any of the oral medications, but the insulin therapy. Yeah, thank you.
I think she was on oral and injectable insulin therapy, as the history said of the patient.
Okay.
Okay.
Dr. Falah Al-Azawi, تفضل.
Yes, thank you, Dr. Hilal, Dr. Aram. Thank you, Dr. Nazar, about this presentation. Really, it's very nice. But about the question, why you not put our prescribed oral anti-diabetic patient? If you start one by one, metformin is contraindication because the GFR 20. When the metformin below 30, GFR below 30 is contraindication, and between 60 and to the 30, you must decrease the dose of the metformin. This is about the metformin. You know about the sulfonylurea with the insulin, maybe increase the risk of the hypoglycemia, and the hypoglycemia and the ischemic heart disease may be lead to more arrhythmia and so on. About the DB4, it is contraindication of the acetagliptin, but the other gliptins need to decrease or adjust the dose, only the tenagliptin, which is not adjusted the gliptin. But also the SGL2 and the heart failure, acute heart failure, it is not contraindication or to give him during the event or during the insult. So as we say that where the patient is stabilized and the start of the SGL2, but not all of the SGL2 because the GFR 20. So only the empagliflozin you can prescribe, and 10 milligram only. About the question of Dr. Nazar, why you using the GLP-1 agonist with the insulin? Because the patient is obese, patient with renal impairment, patient with the hypertension. I think it is very good option for this patient to give GLP because you can give only we could give the GLP in the renal impairment when the GFR below 20 and 20 and below. And about the
Dr. Falah, this is a question. Dr. Falah, العفو. السلام عليكم.
comment about your question. يعني ليش انت ما استخدمت انه option انه GLP and the insulin?
At this time in hospital, Dr. Falah, that's what I
after that انت كاتب after that.
اي هسه نتكلم عن الموضوع.
زين. يبقى انه انت you mention about the GFR and GL2. You mentioned that the 45 to the DAPA and 45 to the IMPA. I think the new guideline that the for IMPA up to 20.
Up to 25.
Sorry.
Less than 30 should not be used.
That's DAPA 25. IMPA up to 20.
All the SGL2.
This is my opinion, and you can say now.
لا, all the SGL2, Dr. Falah, all the SGL2, according to the American Diabetic Association, no SGL2 is properly to be initiated below 30.
I can call you then, and I send you the recommended.
Okay.
You can see it in the American Diabetic Association.
Okay. We can elaborate more in person-to-person discussion about this point.
Because we have 5 minutes only, Dr. Hilal.
Dr. Hilal, there is only one thing about using the GLP-1 with insulin. Yes. GLP-1 with insulin, it should be used in patients who are obese and who do not have extreme symptoms. If the patient is stable and he is properly treated and you didn't reach the goal by having insulin, then you can add the GLP-1 in order to make the insulin work proper. But if the patient is unstable or having symptoms of polyuria, polydipsia, and negative nitrogen balance, then GLP-1 should not be started and the insulin should be more proper to be started. And thank you.
Okay, thank you.
Thank you very much.
أمال إذا تسمحي لي بدقيقتين قبل ما تطلع final messages من البريزنترز. احنا بالحقيقة ليش قدمنا هاي الكيس؟ قدمنا هاي الكيس هي not to review what is going on about everything of a patient with ischemic heart disease, heart failure, diabetes, and renal impairment. The main objective of presenting this case is to focus on the pitfalls that we are doing in our daily practice. If you notice that case history, the patient was not properly treated by guideline-directed medical therapy regarding the doses of anti-failure, anti-ischemic measures. The patient was not followed very well regarding her diabetic control and body weight. The patient was improperly treated. يعني خليني نتكلم بصراحة. Our current practice من مريض يجي ويدخل pulmonary edema and we successfully manage him يرجع للموضوع القديم مالته uncontrolled diabetes, not properly treated ischemic heart disease or heart failure, and then till more complications will happen. معظمنا إذا المريض عنده fever وإجا راح نبلش empirical antibiotic, not as guided by culture and sensitivity, and we depend on that. النقاط اللي ذكرها دكتور آرام very nice بالمانجمنت مالت الكيس والانديكيشن مال الكورونري انجيوغرافي. النقاط اللي ذكرها دكتور صفاء very nice regarding الانيميا, estimated GFR, الفولو اب for estimated GFR, the best drug, the best antihypertensive إلى آخره. بالبراكتس مالتنا احنا مندز المريض ما عدا الهيموغلوبين، مندز للساتوريشن والفيريتين حتى نشوف وات از ذا بروبر، نشوف السيرم فيريتين عالي نقول اوكي المريض اوكي and that's it، بينما هو ساتوريشن مالته هو قليل. ما ندور على الاتونيك بلادر وعلى الكومبليكيشن اللي ممكن المريض هو عنده واحنا ما منتبه لها. نفس الشيء للدايابيتيك كنترول واستخدام الادويه الجديده اللي طلعت SGLT2 inhibitors GLP-1. اذا اخوان الغايه من التقديم the main purpose of presenting this case is that to focus on these things. And thank you very much, Dr. Amal. Probably you ask the presenter for final home messages, please.
Yes, may I ask Dr. Aram, Dr. Safa, and Dr. Nazar to kindly give us and the audience home messages, take-home messages from each one of them. You can start, Dr. Aram, please.
Mute.
Aram.
Mute. Mic is mute.
Thank you very much again, Dr. Amal. Already we have
Yes.
mentioned about the take-home message, but what's important, the main, actually, one of the pitfalls as mentioned by Dr. is the patient, majority of the patient, they are not on optimal medically guideline-directed medical therapy. As I mentioned, we have a lot of patient on small dose of beta blocker for the last 20 years. So please, when you have any patient with heart failure, let's go to maximize the medication up to standard and the guideline mentioned. This is very important. Again, when I are sending the patient or are doing revascularization, there is no shortcut in cardiology. We don't have any shortcut. When I'm going to open one vessel, let's try to open all other vessels to have a complete revascularization, whether in the form of bypass surgery or stenting. And lastly, teamwork is very important. Actually, I have learned a lot from presentation of Dr. Safa and Dr. Nazar, and thanks again. Thank you very much.
Thank you, Aram. Dr. Safa, please. Safa. Okay, Dr. Nazar, are you there?
Yeah, I'm here.
Yes, please.
The major point here is not to leave your patient reaching such a level. Hemoglobin A1C 11 and the blood sugar more than 300, possibly due to the infection, but the hemoglobin A1C 11 is not due to the infection. This is the previous hemoglobin. So you should follow your patient with hemoglobin A1C and repeated readings of sugar at least every 3 months, so that you can decrease the hemoglobin A1C to a level that is acceptable. This is the first one. The second idea is don't be afraid of using more intensive treatment to treat diabetes. The lower the hemoglobin, apart from not making the patient go to hypoglycemia, is the better. So treatment intensification in this patient should have been done previous to this presentation at the emergency. Thank you.
Thank you, Dr. Nazar. Safa, are you there or?
صفاء ما أعرف أكو فد مشكلة بالكونكشن وياه. إذا سمحت دقيقتين أحكي على الويب سايت دكتور حسن مو
أي نعم تفضل تفضل.
It is our proud and pleasure to announce the launch of our new website for the RCP-Iraq network members and fellows. You can see the link of the network. It is that rcp-iraqnetwork.com. You will have this page of the website that includes our missions, our news, steering committee in the program for 2022. Also, you can take around tour in our website, seeing our story, how does it started, and then our vision, missions, and the objectives. The steering committee, which is consists of senior steering committee and junior steering committee, which they are participating in managing the work of the network, as well as to the subgroups that we created in the network, and our courses that we are delivering to our beloved colleagues. we have medical education course, and also we have the research course and events and training. Also, you can follow up our activities and program for 2022, and we will announce every activity on the website. It should be registered. Recently, we will, inshallah, very short time, we will announce the elective training program for medical students in Bristol University, as well as the chances for training of Iraqi postgraduate doctors in UK through the medical training initiative. And this medical training initiative, which include chances to be trained in UK from 6 months to 2 years. So follow our news on the website, and most welcome with all. The final word is yours, Dr. Amal.
Well, I would like to thank you, Dr. Hilal, and all the members of the team and the subgroup of scientific activity, including the seniors and the juniors. And thank you for Dr. Mumtaz and Dr. Omar for being there with us. Thank you very much. Hope to see you in.
Great team from the medical students who support all our work.
Yes, they are really great. Yes. Thank you very much to all, and hope to see you all next time in the next activity.
Omar, just pointing that a newly released newsletter that mentioning the activities of or mentioning the Iraqi network. Omar just stimulated me to say something about that. And okay, that's the newsletter. That's the newsletter. You can see Omar in his lovely smile. And that's from Egypt. Egypt start to also create their network very shortly. And that is the mentioning of our network and our activity and this is the celebration day that was on the 10th of last December. Thank you, Omar, for your great support, you and Mumtaz, and lovely working with you all.
Pleasure.
Thank you.
Always pleasure. Good work. Thank you very much.
Thank you all.
Thank you, Omar.
شكرا للبرزنتر، شكرا دكتورة آمال للموديوريشن، آرام، صفاء، نزار، شكرا للمناقشين الأكتف كانوا أغنوا السيشن بالأسئلة، وإن شاء الله إلى السيشن الثاني اللي راح يجي إن شاء الله ناخذ comorbidity أخرى GIT and rheumatology, atrial fibrillation and stroke, etc. Different subjects will be presented, so keep updated with our website to the next events. شكرا جزيلا ونشوفكم على خير.
Thank you. See you again. Thank you.
Thank you.